Hey everyone, it's good to see you. In this video, I'll be talking a little bit about two ongoing controversies in the field of psychopathology or abnormal psychology. The first has to do with gender dysphoria, and the second has to do with dissociative identity disorder. So I'll tell you a little bit about them, the two or more sides to both issues, tie it together with a couple other ongoing controversies in the field and why I think it's important to consider ongoing controversies, and then wrap it up, and that'll be today's video. So, the first, gender dysphoria, as you may know, refers to this disorder idea when a person is struggling with symptoms that have to do with a significant mismatch between one's assigned sex, typically at birth, and their internal identity or their identification with a gender. So for instance, someone who is born with male genitalia but discovers that they strongly identify with being female may possibly meet criteria for gender dysphoria if they meet the rest of the DSM symptom list, which is pretty simple. You have to have two out of the list that they show there. So the contention or the controversy about this is that essentially one side would argue this is a stigmatizing mislabel for those that are transgender, which is a normative variation of gender identity, right? Just like being cisgender is another variation. The other side of the argument would be that there is an important reason for having that disorder label, that gender dysphoria as something that can be applied to a patient in terms of sticking that diagnosis in their chart, that's an important thing to be able to do for a variety of reasons. So the proponents of using the disorder label might argue things such as, well, it is in fact often very, very distressing for someone to go through the process of realizing that they are trans, possibly coming out to friends and family members, co-workers, and for some, pursuing treatments or possibly surgeries. This whole process is just very difficult, and many societies and cultures are not entirely accepting or aware of these issues quite yet. So to have a moniker for the kinds of difficulties that set of people is going through makes sense. So some would argue that the idea is not to stigmatize and is not to say that being transgender is wrong, but rather to say that gender dysphoria, the distress, is the idea that goes along with that mismatch that's experienced. That would be distressing, that would be difficult, that could be a clinically significant mental health problem. So the opponents to this issue might say things like, this is analogous to back in the 70s when homosexuality was in the DSM, right? It was termed a disorder. It was viewed as abnormal, pathological, unhealthy. And eventually, the research showed this makes no sense. Gay folks, lesbian folks, bisexual folks, on all accounts, are psychologically equal to their straight peers. They are no more disordered, no less intelligent, or any other important psychological criteria. This is just antiquated, right? This is just a label that has stuck around for a long time because at some point someone decided this is wrong. Maybe gender dysphoria is doing the same thing. Maybe it's just a problematic label for trans folks. That would be that side of the argument. So there's some valid points to be had on either end of this. Importantly, the entire psychological scientific community is essentially unanimous in understanding that transgender folks are to be accepted and that is a viable experience of one's gender. It's not about that. What it's about is having this disorder label productive? Is it a way for folks to get insurance reimbursement for the care that they may need? Or is it just doing more harm than good? Is it confusing the public? Is it leading people to believe that it's amoral or somehow unhealthy and wrong to live transgender? So, some difficult contention around that, and the field is obviously not settled. When the DSM-5 came out, gender dysphoria remained on the list of possible disorders that one could be diagnosed with. So at least at this time, the American Psychiatric Association is leaning toward keeping it. That may change in the future. It's hard to tell. So the second contention I wanted to talk a little bit about is about dissociative identity disorder. So the question here is basically, well, what is it? Where does this come from? Primarily because it is such a rare issue. So as you may know, dissociative identity disorder refers to this idea that one's personality splits, or that one is living with multiple senses of self within them, and that as a result of that, you'll have these periods where somebody is, George one day and then Fred the next day. And Fred can't remember what George did the day prior. So there's these blanks of memory that people experience. The different selves are often very different, sometimes different ages, different genders, completely different life experiences and backgrounds. And so as you can imagine, this is a pretty severe rare issue. I mean, we're talking prevalence rates are all estimates at this point. 1 in a million, possibly, maybe more, maybe less. So researchers are sort of undecided about exactly the best way to describe it. So some would argue this is indeed a legitimate mental health disorder. It's just that it does not appear very often. And others would argue this is some byproduct of a societal problem or a problem in our field. So essentially the two stances are the posttraumatic or traumatogenic stance, which argues that DID is the result of recurrent, horrific, ongoing abuse and trauma, especially during childhood, and that essentially what a child does to deal with this trauma is to sort of go into this creative, imaginary friend sort of place in their minds and sort of say to themselves, it's not me that's going through that horrific abuse, it's some other person, some other kid, some other entity, and sort of fantasize about that, right? So they sort of retreat back into their own minds during whatever the abuse may be. They gain practice with that. It keeps developing, and then it may split into more than two personalities. On record, there are some case studies of people with 53 or more different personalities within them, right? So the idea being that this is an extreme response to trauma. That's the traumatogenic or post-traumatic theory of DID. Then the opponents to that are those that would adhere to the sociocognitive model of DID. So the sociocognitive model argues essentially that this is an inflated mimicking of what people see in the media, and that therapists are so fascinated by it that they are accidentally perpetuating it. Another way to put it would be that it's iatrogenic, so caused to some extent by the professional. So the data that supports the sociocognitive theory would be some interesting correlational data on the emergence of TV shows, movies, and books that have to do with this idea of split personalities or dissociation happening along with rises in the estimated prevalence rates. So for instance, things like The Three Faces of Eve, Sybil, the United States of Terra, the recent movie Split, Me, Myself, and Irene, the list goes on, but anytime that another one of these pieces of media comes out, the data appear to show that we see more and more cases. So it could possibly be that people are sort of unknowingly mimicking that media, and then therapists who are so fascinated by those symptoms are encouraging their clients to talk through it, are kind of perpetuating it. So the post-traumatic theory adherents would argue, no, that's just a coincidence. There's really clear data to show that DID cases do in fact have a history of repeated, recurrent, horrific child abuse. And in fact, some studies show that 85% or more of those that have been diagnosed with dissociative identity disorder do in fact report these kinds of really extreme, repetitive traumas throughout early life. So that gives some validity to that argument as well. Again, the field is sort of uncertain about this. That's why there's ongoing contention. So, why is it important to tell you a little bit about the answers that we don't have yet? You might be thinking, I want to study this topic so I can learn what we know. I think it's important to explore what we don't know, and I think it's important to expose to students some of the ongoing questions that we have. This is science. When people say it's not a perfect science, well, there is no perfect science. We're continuing to ask important questions and seek good answers across all fields of science. So these are just a couple examples in psychopathology that are important, but there are many others we could think about. There's ongoing contention, for instance, about whether ADHD is overdiagnosed in children or whether its prevalence rate has climbed for some reason over the past couple decades. There's contention about which forms of treatment are the most appropriate. And that's probably one of the most heated things in clinical psychology that's still going on right now, with this empirically supported cognitive behavioral therapy group sort of clamoring against the humanistic or psychodynamic groups. I could list many other ongoing problems, but my point is there's still much room to grow. There's a lot we don't have quite figured out yet, and hopefully that's motivating to you. Hopefully what that means is that these questions are interesting, there's a lot more to learn, and we're not done yet. So, big picture, there is controversy and contention in a lot of things in clinical psychology. Use that to be motivation to seek good evidence. Don't rely on hunches, don't rely on anecdote, do good research. So, that's the idea. Thanks for watching. Have a great day.